Good day everyone, I am Isli Del Rosario from BSN 111B Group 6. Today I will perform an assessment of the thorax return demonstration. Assessing the thorax is essential to identify underlying respiratory problems and clues about the risk for development of lung disorders. For the pre-introductory phase, first, review the client's previous medical records and doctor's order sheet if available. Previous medical records will help us in understanding the current health status of the patient and to verify the order with the doctor's order sheet. Next is to determine the scope of the assessment needed. In this assessment, complete examination of thorax consists of inspection, palpation, percussion, and auscultation to the posterior and anterior thorax. Also, we must prepare all the materials needed for us to work systematically and efficiently. The materials needed are skin marker to mark the level of the diaphragmatic excursion, ruler to measure the distance of the inspiratory and expiratory excursion, and of course a stethoscope to auscultate the breath sound of the patient. In a clinical setting, examination gown or drape is being utilized so that we can easily access the part of the body where we need to assess without exposing the other parts of the body. Then, do not forget to perform hand washing to avoid the spread of microorganisms. Good day, sir. You may sit down. Good day, sir. I am Isli Del Rosario, a student nurse from Davao Doctors College, Incorporated. So, I already closed the door to ensure your privacy, sir. So, for verification, sir, may I know your name, please?
Kevin Paul Ray Del Rosario.
How about your birthday, sir?
September 13, 2003.
Okay, so how would you like me to call you?
Kevin.
Okay, Kevin. Today, I am going to assess your thorax, which means I need you to ask to stand, to sit down, and to take off your shirt. I will also palpate or touch, percuss, and auscultate some parts of your body, specifically your upper extremities. I will also be marking your skin at your back to measure for your diaphragmatic excursion. Will that be okay with you?
Yes.
Okay, so do you have any questions or clarifications regarding the assessment today?
No.
Okay, so rest assured that all the data gathered in this procedure will all be kept confidential. Okay, so before we start, may I ask if are you comfortable with your seat?
Yes.
How about the temperature? Would you like me to adjust the temperature for you?
No.
Okay, so if you feel uncomfortable or if you have any questions during the assessment, feel free to tell me, okay?
Okay.
Okay. So before I proceed with the assessment, I will be interviewing the patient about his health history, which is composed of the chief complaint, present health status, past health history, current lifestyle, psychosocial status, and of course the family history. This is done to gather subjective data that is essential data to provide information that may reveal a client's risk for a problem. So first, I will be surveying the chest and respiration to look for any signs of respiratory distress, and I will palpate the suprasternal notch and note the position of the trachea. Okay, so first, I will be surveying Kevin for any signs of respiratory distress, such as nasal flaring, pursed lip breathing, and retractions, okay? Okay, so there are no signs of nasal flaring. However, I can observe intercostal retraction, which may indicate narrowing in your airway. Also, I observe the use of your accessory muscle, the sternocleidomastoid, which is also an early sign of airway obstruction, since normally the diaphragm and the external intercostal muscles do most of the work in breathing. Now, I will be palpating or touching your suprasternal notch and note the position of your trachea. Okay? Okay. Okay. So I can observe that your trachea is in the midline. So may I see your fingers, please? On the other side. Okay, so I observe that your skin tone is evenly colored and there are no signs of discoloration or cyanosis in your face, lips, chest, and fingernails. Now, I will be examining the posterior thorax starting with the inspection of configuration, which is the overall structure of the chest. It is important to assess the configuration since this may allow us to see any visible external signs of respiratory function. I will also inspect for the spinal alignment for deformities afterwards. So now, Kevin, I will be examining your posterior or the back of your thorax and lung. So I am going to inspect the chest configuration, which is the overall structure of the chest. So can you please stand up? Okay, and then turn around. And we go there on the other side. Okay. So now I will be examining the posterior thorax, starting with the inspection of configuration, which is the overall structure of the chest. So it is important to assess the configuration configuration since this may allow us to see any visible external signs of respiratory function. I will also inspect for the spinal alignment for deformities afterwards. Okay, so now I will be examining, Kevin, your posterior or the back of your thorax and lung. So I am going to inspect the chest configuration, which is the overall structure of the chest. So can you please stand up? Okay, okay. Okay. So I can see that the scapula are symmetric and non-protruding, and the ratio of your anterior posterior to transverse diameter is 1:2. So now I am going to inspect your spinal alignment to determine any abnormalities in the curvature of your spine, okay? Okay. Okay, so I observed that the cervical, thoracic, and lumbar curvature are all normal. Okay, so can you please bend for me, Kevin, like that? So I am assessing the lateral deviation of your spine. Okay, so I can see that the spine is vertically aligned and straight, and the left and right shoulder and hips are at the same height, which is normal. Okay, you can now sit down, Kevin. Now, I will be palpating the posterior thorax to assess for any bulges or tenderness. I will also palpate for the respiratory excursion or the movement of the thoracic diaphragm during breathing, and the thorax for vocal fremitus or the vibration or intensity felt on the chest. Palpation is an essential in assessing the thorax since there are different abnormalities that can be detected during this part of the assessment. So now, I am going to palpate your posterior thorax, Kevin, okay? Please tell me if you feel any pain, okay? So I am just palpating using the dorsal of my hands to assess for your temperature. Okay, so your skin is warm to touch. Now I am going to assess for bulges, tenderness, or any abnormal movements, okay? Okay, just tell me if you feel any pain, okay? Okay, so there are no tenderness, pain, or unusual sensation in your posterior thorax. So now I will palpate for your respiratory excursion or the thoracic expansion. So can you please inhale and exhale deeply for me, okay? Okay, go. Again, please. Okay, okay. Okay, so I observed that there is a unilateral delay or an equal chest expansion. So there is a delayed expansion in your left posterior chest wall. Okay, so now I am going to palpate for your vocal fremitus, starting at the apex of your lungs, okay? So this is to assess for the increase or decrease of lung density. So can you please count from 1 to 3 when you feel my hands, okay?
Okay.
Example, 1, 2, 3, then 1, 2, 3, okay?
Okay.
Okay, so let's start.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Okay. Okay, so I can feel an increase in tactile fremitus or vibration whenever you say the phrase 1, 2, 3, which is usually due to consolidation or indicative of an increase in the lung density. Okay. So now I am going to percuss the posterior thorax and measure the diaphragmatic excursion. Percussion helps in identifying areas of the lung with abnormalities since this produces audible sounds that can determine fluid, air, or solid materials in the chest. So since the lungs is filled with air, the percuss tone must give resonance. So Kevin, I am going to percuss or do a tapping motion in the posterior thorax to assess for your lungs resonance, okay? So I need you to fold your arms across your chest like this. Okay, to expose to move away the scapula to expose your lung tissue. So I am now going to start percussing, okay? So I will percuss in your intercostal spaces at about 5 centimeter intervals in a systematic sequence. Okay, Kevin?
Okay.
Okay. Okay. Okay, so I can observe asymmetry or different percussion notes. So in some parts, I can observe resonance, which is the normal tone for your lungs tissue. However, I can also observe dullness in some parts of your lungs, which may indicate air or fluid in the lungs. Okay, so Kevin, now I am going to measure for your diaphragmatic excursion. So in this procedure, I will be marking your skin using a marker. So is that okay with you?
Yes.
Okay, so I am going to percuss starting at the scapular line or the T7 downward until the tone changes from resonance to dullness, and then afterwards I will be marking this level. And then, so what I want you to do is to exhale deeply and hold it for me, okay? Okay, so can you please exhale deeply for me? Exhale deeply, then hold it, okay? Hold it for me, thank you. Okay. Okay, so what I want you to do is to inhale deeply and then hold it for me, okay? Okay? Okay, so I will be doing on the other side also. Okay, so please exhale deeply for me. Exhale deeply. And inhale deeply for me, please. And then hold it, okay? Okay, so now I am going to measure for your diaphragmatic excursion using a ruler, okay?
Okay.
Okay, so I can observe that there is an even excursion. So your left diaphragmatic excursion is 7 centimeter while your right excursion is 5 centimeter. Okay? So now I will be auscultating the posterior thorax breath sounds and voice sounds. So auscultation assesses airflow through the trachea bronchial tree. It is important to distinguish normal respiratory sounds from abnormal ones, for example, are crackles, wheezes, and pleural rub, in order to make correct diagnosis. Okay, Kevin, now I am going to auscultate or listen for your breath sounds using the diaphragm of the stethoscope, since it is best used for transmitting high pitch sound. So I am just disinfecting the stethoscope. So what I want you to do is to breathe deeply through your mouth, Kevin, okay? This is to avoid transmission of sounds that may occur during nasal breathing, okay?
Okay.
Okay, so inhale, exhale. Again. Okay. Okay. Okay, so I can hear some adventitious sound upon auscultating your posterior thorax. So may I ask you to cough, since coughing may clear the lungs, and then I am going to auscultate it again to ensure if the sound that I heard is adventitious, okay? Okay, can you please cough? Okay, so I am going to listen again, okay? Okay. So inhale, exhale. Okay, so I can hear some harsh, loud, high-pitched sound or bronchial breath sounds in the lung parenchyma. So usually bronchial breath sound is heard on the trachea and thorax. However, in your case, Kevin, I can hear it in your lung parenchyma, which is not considered to be normal. I can also hear some low-pitched bubbling moist sound during inspiration, which can be coarse crackle in the left lower lobe of your lungs. So now I am going to auscultate for your voice sound, starting with the bronchophony, okay? So what I want you to do is to say 99 while I auscultate your chest wall, okay?
Okay.
So 99, okay?
Okay. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99.
Okay. Okay, so normal lungs are filled with air and air does not transmit sound readily. So normally transmitted voice sounds are difficult to hear, meaning spoken words are muffled and indistinct, and whispered words are usually not heard at all. However, in your case, the voice transmission is clear and distinct, meaning I can easily understand the phrase that you are saying. And so this is one of the signs of consolidation, or there is an increased density in the lung tissue. Okay, so now I want you to say the word letter E while I auscultate your chest wall, okay?
Okay.
Okay, so let's start.
E. 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 A. E. 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 E.
Okay. Okay, so I can hear the letter A instead of E, which is also an indication of consolidation or compression in the lungs. So now what I want you to say is the phrase 1, 2, 3, okay? Whenever I auscultate your chest, okay?
Okay.
Okay.
1, 2, 3.
Just whisper it. Okay, so the transmission of the sound is clear and distinct, which is also an indication of consolidation or compression on the lungs. Okay? So now I am going to assess the anterior thorax, starting with the inspection of the breathing pattern and costal angle. So now, Kevin, I am going to proceed to your anterior thorax. So I need you to lie down here in the bed, please. Okay, so I am just inspecting your breathing pattern. Okay, so I can observe quick and shallow breaths. So there is an increase in respiratory rate and irregular breathing. So I also observed that the ribs slope downward with symmetric intercostal spaces and the costal angle is within 90 degrees. So now, Kevin, I am going to palpate or touch your anterior thorax. So, okay, I'm gonna palpate. I'm just looking for any tenderness. Tell me if you feel something, okay? Okay. Okay, Kevin. So now I am going to palpate for your premitus or the vibration in your chest wall, okay? So can you say the phrase 1, 2, 3 whenever I palpate your chest, okay?
Okay.
Okay, let's start.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Okay. Okay, so there is an increased or larger vibration in your premitus. So now I am going to palpate for the anterior thorax for respiratory excursion or the chest expansion, which is the movement of the thoracic diaphragm during breathing. Okay, Kevin?
Okay.
So now what I want you to do is to take a deep breath, okay? Okay, just like what we did on your posterior thorax, okay? Okay, inhale, exhale, please. Okay, so just like in your posterior thorax, I observed that there is a unilateral delay or an equal chest expansion. So there is a delay in your left anterior chest wall, okay?
Okay.
So now I am going to percuss the anterior thorax in a systematic way. Okay, now Kevin, I am going to percuss for your anterior thorax. So I am going to percuss above your clavicles in the supraclavicular space down to your diaphragm, okay?
Okay.
Okay. Okay. Okay, Kevin, just like in your posterior thorax, I can also observe asymmetry or different percussion notes. So in some parts, I can observe resonance, which is the normal tone for your lung tissue. However, I also observe dullness in some parts of your lungs, which may indicate air or fluid in the lungs. So now I will auscultate the anterior breath sounds. Okay, Kevin, I am going to auscultate your trachea first, okay?
Okay.
Okay, so I can hear high-pitched whistling noise, probably because of the cough that you've mentioned earlier during our history-taking interview. Okay, so now I am going to auscultate the anterior thorax. So I am going to place the diaphragm on the diaphragm of the stethoscope on your anterior thorax, okay?
Okay.
So I am going to start above the clavicles down to the base of your lungs at the sixth rib. So what I want you to do is to exhale and inhale deeply, okay?
Okay.
Okay. This is to avoid transmission of sounds that may occur during nasal breathing. Okay, so let's start. Okay. Okay, so I can hear some coarse crackle here at the left lower lobe of your lungs during inspiration or when you breathe in. So, okay, you can now sit down, Kevin. So I am just going to take note all of the findings in this assessment, okay? So Kevin, for our assessment for today during the inspection of your posterior thorax, so for your chest configuration, I can observe that it is symmetric and the anterior posterior is normal in ratio. There are also no signs of abnormalities in your spinal alignment. However, I can observe that there is an intercostal retraction or the muscles between your ribs are pulled inward, which may indicate narrowing in your airway. I also observed the usage of sternocleidomastoid here in your neck, which is also an early signs of airway obstruction since usually the intercostal muscle, both the internal and external and the diaphragm, are responsible for the work in breathing. Okay, for the palpation, the temperature of your skin is warm to touch. No signs of tenders or any abnormal movements or any pain or unusual sensation in your posterior thorax. However, during the respiratory excursion or the thoracic expansion, there is a delayed expansion in your left posterior chest. Um, and for your vocal fremitus, there is an increased tactile fremitus or vibration, which is usually due to consolidation or increased lung density. And when I percuss your posterior thorax or the tapping motion at your back, I observe different percussion notes. So there are areas where I can observe dullness instead of resonance, which is the normal tone for the lungs. Okay, and for the diaphragmatic excursion, I also observe uneven measurements in your left and right diaphragmatic excursion. So with your left having 7 centimeter and right having 5 centimeter. Upon auscultating your back, I observe a low-pitched bubbling moist sound or coarse crackles every time you inhale in your left lower lobe of your lungs. And for your voice sound, the bronchophony, remember when you were saying 99, then your egophony when you are saying the letter E, and then the whispered pectoriloquy when you are saying 1, 2, 3. So the three of them resulted in an abnormal finding, which can be an indication of consolidation or lung expansion. Okay, for your anterior thorax, I observe quick and shallow breaths. There is also an increase in respiratory rate and there is an irregular breathing. No tenderness surface, masses, or crepitus was observed. However, there is an increased vibration in your fremitus, which means that there is an increased density within the lung tissue. So just like at your posterior thorax, there is also a delay in the expansion in your left anterior chest wall during my assessment for your respiratory excursion. I also observe some dullness in your lung tissue instead of resonance, and I can hear some adventitious sound, specifically coarse crackle in the left lower lobe of your lungs. Okay, so all the results of this assessment will all be handed to the physician to further assess your current health status. So since you are having difficulty in breathing, I can advise you to perform coughing and deep breathing exercises since this can help in clearing the airways. Also, since there is a presence of purulent phlegm, you can increase your oral fluid intake since it can help loosen thick purulent sputum. So I will also be monitoring your respiratory status to determine if there are any changes in your current health status. Okay, so do you have any questions or clarifications before we end?
No.
Okay, so thank you so much, Kevin, for your cooperation, and we will just call you for your follow-up assessment. Thank you so much.